Hello everyone, how are you all? Welcome to another free 2-week session class. So tonight we're going to do cardiology. And I guess that many of you were in our cardiology theory session 1, right? I know that back to back you are getting 2 classes and that can be quite stressing for a lot of you. But it's important to differentiate between a theory session and a random role play session. If I were in your place, I would not bother too much with the random role play session right now. I would mainly focus on theory classes at the moment because it makes more sense rather than doing a random role play just at the first. The class yesterday, it was mainly focused on, it's one of our class in every week so that you know how we are going to plan this course, just to show you that. But random role play session, it starts to make sense. Usually, I would say after 1 or 2 months of having a good theory knowledge and how to start a case, the approach and ending, everything. When you will get a hold onto these things, then cases becomes a lot more easier. All right. So don't bother too much with that. I know that it was hard for a lot of you yesterday, but all of you who did role play, you did really, really nice. All right, so tonight we are going to finish cardiology most likely. And we did one cluster, which was your syncope cluster. Do you guys have any question on that syncope cluster that we have done? All good. Great. So let's start then. Now, there are 2 other clusters which is quite important for your exam. One is palpitation cluster. Palpitation cluster will also cover nervousness, anxious cluster. Pretty much same differential diagnosis and everything. So mainly we'll focus on palpitation cluster. There are a couple of cases which comes in exam very frequently. And another is also very, very important for the exam. That's your chest pain cluster. It's super important. And tonight class will also focus on ECG a little bit because all these clusters are ECG based cases. And again, as I said initially, that you don't need to have a very, very good idea on ECG for part 2 or AMC clinical exam, unlike your MCQ exam. So just the important ECG, you need to know how to discuss those and how to diagnose those cases. All good. So starting with the palpitation or nervousness cluster. So what could be the differential diagnosis of this cluster? As you remember, we always focus on differential diagnosis first, followed by we go to the history format. And just by using that same history format, we try to finish as much cases as possible. Like with the syncope cluster, we finished 6 cases, and that was huge. And you guys obviously understood that how easier it becomes if you just use one history format, one physical examination format for 6 or 7 cases. It becomes so easier. Now, whenever a patient presents to you with palpitation, or sometimes patient just comes to you with feeling unwell, or sometimes they just say they're having a jumpy heart, or they say that their heart is feeling funny, or some patients say racing of the heart. So all of these are same. So if patient saying, doctor, my heart is so jumpy these days, or my heart feels funny to me. So you just need to think that feeling funny means they're trying to say it's palpitation. If you don't understand something, like feeling funny can be anything, right? You can always ask it to them. Can you please tell me a little bit more about it? Like what exactly you mean by feeling funny in your heart? And then they maybe show to you, or they will discuss in detail about that. So don't assume anything if you are not sure. Just ask the patient to discuss in detail. Okay. Now, differential diagnosis of palpitation, the most important system is cardiovascular system, which will include ischemic heart disease, myocardial infarction. Hypertension sometimes can cause palpitation or nervousness. Arrhythmia is very, very important differential, and sometimes valvular heart disease. Not very common, but commonly ischemic heart disease or MI and arrhythmia, these are common causes. We also try to rule out CNS causes, especially for nervousness, not too much for palpitation, but still you would ask this differential diagnosis in your case. Remember the CNS causes always same: trauma, tumor, infection, stroke, and epilepsy. It's always same. Then go for endocrine. You can always add endocrine and electrolyte abnormalities. In endocrine, thyroid disorders, then hypoglycemia can cause palpitation, pheochromocytoma can cause palpitation, and very important is hyperthyroidism. You can always add in here electrolyte abnormalities, like if someone is having hypokalemia, that can cause palpitation, hyperkalemia can cause palpitation, hyponatremia can cause palpitation. So electrolyte abnormality due to severe vomiting, severe diarrhea can be one of your DD. Then you have anemia and anxiety disorder. So anemia, obviously, if you're lacking of enough hemoglobin in your blood, your heart will try to pump faster to provide enough blood supply to your vital organs of the body. So that's anemia is one of the important DD. Any anxiety disorder, especially panic attack, panic disorder, stress, all of these psychological issues can cause palpitation, can cause nervousness. If a patient comes to you who is like above 40-year-old and female, you should always rule out menopause if their symptoms is like just palpitation, feeling nervous, sleeping difficulty, feeling hot and sweaty. So you should always rule out perimenopausal symptoms at that time. Excess tea, coffee, recreational drugs, or even alcohol intoxication or alcohol withdrawal can be a DD. And sometimes some of the medication can cause palpitation. One of the very common one is, let's say someone is asthmatic or COPD patient and he's using too much Ventolin or beta agonist drugs, and that salbutamol, Ventolin, those inhaler can cause tachycardia or palpitation. All right, so try to rule out all of these things. Another important thing that you can rule out is respiratory related cause, especially pulmonary embolism can cause tachycardia or palpitation sometimes. If it's very acute onset of tachycardia, you should rule out pulmonary embolism as well. Okay, so this will be your differential diagnosis. So if you just want to remember, it's very easy if you follow my thinking level. Like I always remember by 2C, 2M, 2E in this way. Rather than memorizing a specific mnemonic, it's easier for me to just remember 2C, 2E, 2A, 2M. Okay, and sometimes that can be a mnemonic, like I will remember it by MECA. Okay, and it's anything you are happy, or you can remember by your own mnemonic. For differential diagnosis, these mnemonics are really helpful, because if you can just remember some of these differential during your first 2 minutes time outside, that will make a huge difference in your case. Sorry, my headphone actually just dropped off from my ear. Okay, now MECA will be a good mnemonic for palpitation. M for 2M for medication and menopause, 2C for CNS CVS, 2E for endocrine electrolyte, and 2A for anemia anxiety. So actually all the differentials which is important for this cluster, you will be easily remembering this just by remembering MECA or 2C, 2E, 2A, 2M, whatever works for you guys. Once you know about this differential, it becomes so easy to ask history, because a lot of questions already will be in your head that you want to rule out. And always, when you know the DD, You just ask 1 or 2 questions for those differential diagnoses, and you pass the history immediately. Now, for someone who is having palpitation, and it will be recent onset always, so in those cases, you need to make sure that patient is vitally stable. So remember how we started our case initially. It's the same introduction for almost all cases, so that it becomes easier for you to start. And because examiner will be different for different cases, if you are using your same introduction everywhere, it doesn't matter. But try to make a little bit of change depending on the case. So let's say this is John. Hi, John. This is Dr. Arshan, one of the doctor here. It's very nice to meet you. I got to know from the notes that you are having racing of your heart for a couple of days, or you are having racing of your heart since the last 2 hours. You must be really scared about it, but please don't worry. Now that you are here, I'll try my best to manage your symptoms. How are you feeling at the moment? Are you comfortable enough? Yes, doctor. John, please excuse me for a moment. I would make sure you are vitally stable so that you can talk to me without any trouble. Is that okay with you? Yes, doctor. Now, if it's an online exam, you will not bother it asking with the examiner because examiner doesn't answer your question. If it's a face-to-face, yes, you will turn to the examiner and ask the examiner that, dear examiner, is my patient vitally stable for further history? Examiner says, what do you want to know? You will say, for palpitation case, we want to know the pulse rate and rhythm. So say that, doctor, I would like to know the blood pressure. I would like to know the pulse rate with rhythm. So examiner will give you the finding. And also I would like to know the respiratory rate, oxygen saturation, and temperature. So you need to know this. Once you know this patient is vitally stable, you can go back to the patient and start asking questions. So let's say patient is vitally stable. We'll talk about the vitally unstable case in the chest pain cluster. So patient is stable. So you turn to the patient in face-to-face and say, thank you so much, John, for waiting for me. Now that I confirm that you are stable enough to answer my questions, would you please tell me a little bit more about your racing of the heart? So patient will give you a lot of information like, doctor, this is not the first time this happened. It's been happening for the last 3 months. It comes and goes. It always starts when I'm doing this stuff. And sometimes it just goes away by its own. But today it's not going away. So that's why I came here. So you know some of these stuffs already. You just need to find out some of the other information from the patient. So you need to know how long this is happening. You need to know when did it start first? Did it start suddenly or gradually? Now, first start with the recent onset and then go to the previous episode. So say that when did it start this time? Doctor, 2 hours ago. Did it start suddenly or gradually? Suddenly, doctor. What exactly were you doing at that time? I was running. Well, is it for the first time? No, doctor, it's not the first time. So can you tell me how many episodes you had so far? 3 episodes. Well, please discuss those 3 episodes with me, like what exactly were you doing at that time and how long that persisted and how it stopped. So patient will give you some of the episodes and discuss about, sometimes I was just sitting in the table and it started and it goes away by its own. I did not do anything. And in sometime I just get up early in the morning and then I started to having this feeling. So they will give you some information. You just need to keep it in your mind. And then what else you need to know? You need to know, is it anything makes it worse? Anything makes it better? Is it continuous or on and off? And how long this episode lasts normally? And how does this episode last? Do you do anything to stop it or does it stop by its own? Okay, so any presenting complaint should be in detail. So that's what we call as HOPC. I will use this term a lot throughout the course. So you will know what is HOPC. That's history of presenting complaint. What is the presenting complaint for this patient? Palpitation. So we are going in detail about it. So anytime any history, we should always go in detail first about the history of presenting complaint. Like this patient having palpitation, we are going in detail of that. Once you have done the palpitation detailed question, then you move into associated symptoms. The people used to ask the patient that, can you show it on the table? How does it feel like? Or can you tap it on the table to show me how does it feel like? It's not necessary. It's just a waste of time. Okay? Don't do that. Once you have done with the palpitation question, then move to the associated symptoms. So along with your racing of the heart, are you feeling any dizziness or lightheadedness? It's a very common associated symptom with palpitation that they used to feel dizzy and lightheadedness. If they have dizzy or lightheadedness, your next question should be anytime you had a fall or you lost your consciousness because of that. Then try to rule out heart or CVS related question by this time. So you're actually starting your DD by this time. So ask about any chest pain, shortness of breath, any nausea, vomiting, or excess sweating. Nausea, vomiting, and excess sweating, that's for MI or ischemic heart disease. And also you are asking chest pain, shortness of breath. So what you are doing, you are trying to rule out CVS differential diagnosis by them. Okay. And then come to the CNS differential, any headache, any problem with your vision or speech, any weakness in anywhere in your body, and any loss of consciousness anytime. So you already asked differential diagnosis in terms of CVS and CNS. Then you go into further differential diagnosis of palpitation. So then you have 2E, remember, endocrine and electrolyte. So for endocrine, hyperthyroidism is very important to rule out. There are cases comes with similar palpitation and turns out it's a case of hyperthyroidism. So we ask one question always for hyper or hypothyroidism, like, have you noticed any recent change in your weather preference? Now, a lot of patients has difficulty to understand this question, and a lot of them actually understand. Now, some patients, they will ask you back that, what do you mean, doctor? What is weather preference? In that time, you have to ask in detail, like, John, sometimes some people feels very cold, even though others are feeling hot. So do you feel very cold, even it's a hot, sunny weather? That's mainly for hypo. Hypo patient will feel cold. And hyper patient, they will feel very hot and sweaty. So you can say that, do you feel excessively hot and sweaty, even though it's a cold weather? And that's one of the feature of hyperthyroidism patient. And what else? You can ask about, have you noticed any changes in your weight or appetite? Hyperthyroidism patient will have increased appetite, rather they will lose weight. So that's very common symptoms. So they're taking food, they're having good appetite, but still they're losing weight. And they will have change in the bowel habit, so they usually get diarrhea. So these are usually normal questions for hyperthyroidism that you should ask. After that, that's your pheochromocytoma. Pheochromocytoma means it's a like adrenal medullary tumor, right? So if someone having pheochromocytoma, they usually get a paroxysmal symptoms, which consists of hypertension, excessively sweaty, headache, and flushing of the face with palpitation. So 4 or 5 symptoms, and that lasts for few minutes or hours, and then it's totally fine. That's how pheochromocytoma patient present. So you already know this patient having palpitation, you ask the other question, like, do you get any episodic headache, flushing of your face, or sweating? I haven't seen pheochromocytoma to come in exam, so don't think about it too much. Then hypoglycemia. Do you skip your, or you can say, did you skip your meal today before this racing of the heart started? And do you have any history of diabetes? So you are finished with endocrine. hyperthyroid, pheochromocytoma, and hypoglycemia. The next question is electrolyte abnormality. So you can ask here that any vomiting or diarrhea recently. Sometimes infection can cause tachycardia, like if you are having fever or septicemia, that can also cause palpitation. So you can ask to them like any fever, cough, runny nose. Then there is anemia. So for anemia, you just ask, do you feel tired or fatigued these days? And you can also ask if they feel tired or fatigued, then we will go in detail about anemia. Like we will ask about their dietary history. We will ask about their any bleeding from anywhere, especially with the bowel motion. For anemia, just one question is enough. Okay. So we asked endocrine, we asked electrolyte abnormalities. Then we are asking about anemia. You can add infection in one of your differential diagnoses. That should be a good idea also. Then ask about SADMA. So do you smoke or drink alcohol? Do you drink a lot of tea or coffee? Any use of recreational drugs? Ask about past medical history. Especially ask about diabetes, hypertension, or high blood pressure, or heart disease. Family history of sudden cardiac death is very important for arrhythmia. Ask about their social history to rule out any stress or anxiety-related problem. So say that, John, I'm going to ask you about your family situation. I want you to know that this will be confidential. So who do you live with at home? Are you a happy family? Do you have any stress at your home or at your work? To rule out generalized anxiety disorder, you can ask them that, do you worry a lot about most of the trivial things? Or directly, sometimes we ask that, are you usually an anxious personality? Okay, so that's your anxiety-related cause. If it's a female patient, we have to ask about their last menstrual period and their menopausal symptoms if the age is more than 40. Okay. So that's pretty much everything about your history of palpitation. So if we go for it, you can see that everything we have already asked from our history pattern. So just as a recapitulation, you reassure the patient after introduction, make sure patient is vitally stable, and then you move on to the history of presenting complaint, which is palpitation, then associated lightheadedness or dizziness. Then you go to the differential diagnosis, starting with CVS question, then CNS question, then endocrine, then electrolyte related question. Then you ask anemia, infection, and lastly, you just finish with social history to rule out stress. You ask about anxiety-related disorder question. You ask about SADMA, tea, coffee, past medical history, and family history. If in your head you can just remember in this way, there is no way you will forget anything. All good, guys? Any question with the history? Because this history, we are going to use it for our all the palpitation cluster cages. Now, physical examination. Remember that there are two forms of physical examination. One is for face-to-face, in which you have to ask physical examination finding from the examiner, and whatever you are asking, examiner will give it to you. And there is another for online exam, in which they most of the time provide you a PEFE card on the screen, and you don't need to ask anything from the examiner. In terms of face-to-face PEFE, what we are going to ask is the same thing that we have asked in syncope cluster. Nothing has been changed. So remember, we discussed all of these things already. So you will just ask general appearance in the pickled pallor, icterus, dehydration, edema, vitals, and BMI. You will go for the neck for raised JVP or carotid bruit. You will do the CVS exam in full, CNS exam in full. You should also do the thyroid examination just to rule out hyperthyroidism, and then finish with urine dipstick, blood sugar, and ECG. I'm not going in detail about it because we already discussed it in our syncope cluster, right? So just follow that. Now moving into the cases. Supraventricular tachycardia is one of the important case for the exam. So you are a junior HMO in emergency department. A man came in with thumping or racing heart and giddiness, which has started today. Your task is to take history from the patient, physical exam from examiner, ask investigation from examiner, explain the diagnosis and differential diagnosis to the patient. So this is exactly how it comes in face-to-face. Whereas if it's online, they will say that PFE on card, which will be given on the screen after 4 minutes. Then in 4 minutes, you will get a prompt from the invigilator that your 4 minutes is up. Remember, there is no clock on your screen. There is no clock which you can see in your face-to-face. So there is no clock. You have to understand the clock is ticking by your head, okay? So the positive points in this case was patient came to you with feeling palpitation, lightheadedness for the last 2 hours, also having some shortness of breath. Previously, 3 episodes which started suddenly lasted 2 hours and then stopped by its own. Patient also takes 6 to 8 cups of coffee a day, which is abnormal. So for arrhythmic cases or palpitation cases, tea, coffee is important. No smoking or alcohol, no previous or family history of heart disease. Patient is an anxious personality, so a lot of positive findings you are getting. And also sometimes they can say that patient is under a lot of stress. Always remember, someone who is having palpitation and you can see on the ECG that patient having SVT, don't just finish your diagnosis by saying it's SVT causing the palpitation. Always say that if you get excess tea, coffee in your history, you should say that this could be also the cause of your having palpitation. If patient is an anxious personality, you should always add that you can have generalized anxiety disorder, which can precipitate this palpitation. You should always give as differential diagnosis as you can, and do not forget to add the positive findings in your diagnosis. Now, looking at this ECG, so your history will cover by the format that we have discussed. Physical examination is covered already. The third task is ask investigation from examiner. In a palpitation cluster, when this task is there, you can't forget about asking ECG from the examiner. When you ask ECG from the examiner will show it to you in the screen, or they will give it to you in the face-to-face exam. Whenever examiner gives you the ECG, you should explain the ECG to the examiner, even though it is not given as a task. Okay? Now, they might not cut any mark if it is not written in the task that ask investigation from examiner and explain it to the examiner. That should be the full task. Sometimes, if explain the investigation to the examiner, if this part is not there, and if you don't explain it, that should be fine. But in my experience, it's a good idea always, if they give you any picture, if they give you any ECG, anything that they give you as part of investigation, you should explain it, that what you are actually looking at. It's a very good idea. But if you are running out of time, don't bother. Now, let's say that one of the tasks in here is to explain this ECG to the examiner. So how we can do that? When we explain ECG to the examiner, we follow a format. Let me show it to you. We always say that, dear examiner, I would like to describe the 12-lead ECG of my patient, Mr. John, a 25-year-old patient coming with sudden onset palpitation and lightheadedness for the last 2 hours. The ECG shows, so when you explain ECG, it should not be a like a haphazard explanation. It should have a format or sequence. So you will start with heart rate, then rhythm, and then remember that this is P wave followed by QRS complex, and then T wave. That's your ECG, right? So you start with your P wave. So is it absent or present? Is it normal in size and shape or not? Then go to the QRS complex. Is it a normal QRS complex, or is it narrow or wide QRS complex? Talk about ST wave. Is the ST wave in normal baseline, or is there any ST elevation or depression? Talk about T wave. Is the T wave normal in size and shape, or is it a tall peaked T wave, or is it a T inversion? And lastly, talk about QT interval. Okay, so this should be your sequence of ECG explanation. Now, when you get a SVT in your exam, look at this. This is exactly how it should be. In case of supraventricular tachycardia, you get your heart rate obviously will be high. So how you measure heart rate? In exam, it doesn't need to be exactly correct. If you just say the approximate heart rate, that should be fine. So in case of heart rate, we always measure it by the RR interval. See, this is one R, this is one R, this is another R. You can find out all the RR interval, they are equally spaced. And that means it's a regular rhythm. When you want to measure the heart rate, just find out the number of large square in between two RR interval. Now, if you see in here, we can say that mostly mostly one large square, 1, 2, 3, 4, 5. So one large square in between two RR interval. So you just remember it by 300 divided by 1. So this patient having a heart rate of 300. Sometimes if there is two large square in between two RR interval, that becomes 150. Right? If there is three large square in between two RR interval, that becomes 100. And then it becomes 75. So it's very easy. You just remember that if it's a one large square in between two RR interval, heart rate is 300. Two large square in between two RR interval, that's 150. Then we have 100 and then 75. You just remember this number. And most of the time, this will be your heart rate in the exam. For irregular heart rate, like atrial fibrillation, you don't need to comment on the heart rate exactly because it's very hard. The time that they give it to you in the exam, you can't measure or determine the heart rate for irregular heart rate like AF. So don't bother with that. Just say heart rate is elevated and irregular in rhythm. That should be fine. Same like if you are not sure about the heart rate, you can just say heart rate is increased, rate and rhythm is irregular or regular. That's also fine. They are not going to fail you for that. So in case of SVT, obviously the heart rate will be increased, as you can see, but it will be a regular rhythm. After that, you look into the P wave. There is no P wave in here. This is the T wave you can see because it's after QRS complex. Okay, P wave is absent. So absent of P wave. Then QRS complex. QRS complex, normally we say the normal QRS complex should be between 1, you can say between 2 to 3 small square. If there is less than 2 small square in the QRS complex, so that's your QRS complex, you can see it's only 1 small square, even smaller than that. And that's what we call as narrow QRS complex. So this patient having a narrow complex tachycardia. Narrow complex tachycardia with a regular rhythm, most of the time that's SVT. Okay, so Now you can explain that, dear doctor, this is the 12 lead ECG of my patient John, who presented to me with a feeling of palpitation and lightheadedness for the last 2 hours. The ECG shows heart rate 300 beat per minute, regular in rhythm, absence of P wave, QRS complex is narrow, there is no ST wave changes, or there is no ST segment changes. T wave is normal in size and shape, and QT interval is normal. I am suspecting this is a supraventricular tachycardia ECG. That's your explanation of ECG to the examiner. It's so follow this sequence in the exam. You automatically have a very good impression by doing this kind of sequence and format. An examiner understand that you are not here just doing some chaos or haphazard case. You are following something, and that means a lot. So that's your ECG explanation. Now you need to explain the condition to the patient. You don't need to explain the ECG to the patient. You just explain in a very simple way, as I always say. So say that from the history, physical examination, and electrocardiogram that we have done, John, I am suspecting the cause of your feeling funny in your heart is most likely due to a condition known as supraventricular tachycardia. Please excuse my medical jargon. I'm going to explain it to you what it means. So remember, the nurse put some cord on your chest today and did a test. The test is known as ECG, which records the electrical impulse in our heart. Let me draw a picture of the heart and discuss it in detail. So this is our heart, the electrical impulse. So you can just draw quickly. So this is our heart. The electrical impulse originates from here and then goes all over the heart to pump blood to your body. In your case, there is some abnormality in this electrical impulse, causing your heart to beat faster than normal. And that is why you are having racing of your heart, or you are feeling funny in your heart. And as your heart is not getting enough time to fill in, your brain is not getting enough blood. And that's why you are also feeling giddy or lightheadedness. Are you with me so far? Do you understand what I'm saying, John? Yes, doctor, that's fine. John, this could be due to many other reasons as well. So then you give all the differential diagnosis. So you can say it could be any other arrhythmia, but the ECG says that you are most likely having supraventricular tachycardia. It could be ischemic heart disease or heart attack, but you don't have any chest pain. You don't have any ECG changes of similar condition. It could be due to anemia, but you don't look pale, or you are not having tiredness or fatigue. So give all the differential diagnosis that you are asking. Okay. Now, when you get some other positive finding, like if this patient is drinking a lot of tea, coffee, you should always address that. Say that the feeling of palpitation can be also exacerbated by drinking a lot of coffee. You should not drink 6 to 8 cups of coffee in a day. This can increase palpitation or racing of your heart. I would advise you to limit it to 1 to 2 cups a day. Okay. If the patient is an anxious personality, you always address that as well, that as you are an anxious personality, I'm suspecting that this palpitation can be related to another psychiatric condition known as generalized anxiety disorder. I would take a further psychiatric history to evaluate that again. Okay. No, in online exam, I would not say that you should draw a diagram. It becomes so hard for anyone to understand what you have drawn. Okay, because in video, it becomes kind of like haphazard image. So it's very hard. You can use your hand to show it, that's fine. But don't show heart as a love sign in your hand. Okay. That sometimes a lot of candidates do. You should not do that. And Dr. Nidhi, I would say, like, if you get some time, always try to explain the ECG. Okay. It's a very good idea. All good. So let's move on to the next one. Exactly same. You will find out how easy it becomes when you know the clusters clearly. The same thing, a patient coming to you in the ED with a sudden onset palpitation, your task is also same, but in case of AF cases or atrial fibrillation, sometimes they ask you that explain the cause and complication of the condition. So then you have to explain what could be the cause of AF and what could be the complication of the condition. Now, history is totally same. Nothing you will get apart from what you have already done. So palpitation, some of the previous episode, all are same. Sometimes in your history, you can get patient is a hypertensive patient. So hypertension is one of the cause of AF. Same with hyperthyroidism can cause AF. So you will ask these questions already in the history. If you get a positive finding, you can use that as a cause for this patient's AF. Now remember, exam for SVT-AF, so don't bother too much with that. But if you want to know, I can just give you a little bit idea. It's exactly the same as you learned in your MCQ. For supraventricular tachycardia, first thing you find out if this patient is vitally stable or not. If this patient is vitally unstable, which means patient is hypotensive or in shock, patient is having altered consciousness level, patient is having severe chest pain, okay, those shows that patient is unstable. Unstable patient will go for DC shock immediately. If it's a stable patient, most of the SVT patient will be stable. In a stable patient, you first try with the conservative approach. So you can try any of the vagal Valsalva maneuver or vagal nerve stimulation. So anything which stimulates the vagal nerve, you can try Valsalva maneuver. You can also try carotid sinus massage. You can try immersion of the face in the cold water. So any of these conservative management will be fine. If that doesn't help, then this patient needs medication. You can either use adenosine or beta blocker. If still that doesn't help, then DC cardioversion, your last choice. That's SVT management. I have never seen it coming in exam, but it's a good idea just to remember. If in case comes, you will be able to say something. Next is your atrial fibrillation. Have a look into the ECG, what you can see in the ECG. Always look at the long lead. You can see that this is the long lead, lead 2. And you already know that this patient is having palpitation. So you don't need to bother too much with ST wave changes. In exam, it's also important to be smart. Okay. Now, in a real life scenario, obviously we would look for ST wave changes first because we want to rule out MI always. But for exam, it's important to be a little bit of smart as well. It's not always like thinking like a normal scenario, because in exam you don't have that much time. Being smart saves time. Now you already know this patient is having palpitation, so obviously this patient having something in the lead 2 or long lead. So you look at the long lead first, and you will always find something abnormal here. So if you look at here, you can already see that RR interval, it's irregular. Irregular rhythm like this, most likely it's atrial fibrillation. How you can be more confirmed? You can look at the P wave. There is no P wave, you will be able to find out. The P wave in here will be replaced by some fibrillatory wave like this. Okay, this is T wave that you are seeing. T wave is normal. Okay, so there is no P wave. How you explain this ECG? So in this case, don't bother with heart rate because you will not be able to say something. It's very hard to say the heart rate in irregular rhythm. So don't bother. Say that heart rate is increased, irregular in rhythm, absence of P wave, which is replaced by fibrillatory F wave, narrow QRS complex, no ST wave changes, T wave normal in size and shape, QT interval is normal, and your diagnosis is atrial fibrillation. Sometimes atrial flutter comes in exam also. The only difference in atrial flutter is that the wave will be sawtooth appearance like this. Okay. An atrial flutter can be regular in rhythm, can be irregular in rhythm. So it depends on if it's a constant block, 3:1 block or 2:1 block in ECG, then atrial flutter will be regular rhythm. If there is variable block, then it will be irregular rhythm. I know it's little hard for you. Let's explain a little bit. So let's say atrial flutter Now, what you are seeing in here is this is called sawtooth appearance. There are 3 P wave followed by 1 QRS complex. That's called 3:1 block. In here, 1, 2, 3, 4, 5. So 5:1 block. In here, it's more like let's say 8 or 9:1 block. That's a variable block. In this case, your RR interval will be irregular. But if someone having 3:1 block all the time, then always your RR interval will be normal. So atrial flutter, you can get regular rhythm or irregular rhythm based on the block that they are having. Okay, so just remember it. Atrial flutter is not so important for exam. Atrial fibrillation is most important. But now you know about flutter as well. So whatever comes in the exam, just follow your knowledge of flutter and fibrillation. In fibrillation, you can always find out fibrillatory waves are like this, like a lot of waves, and it's not sawtooth like this. When it's sawtooth like this, that's flutter. When it's fibrillatory or wavy pattern, that's your fibrillatory F wave, which we find in atrial fibrillation patient. Now explain to the patient, what is atrial fibrillation? Same. Guys, remember the SVT explanation? You explain it totally same, because there is nothing we have explained about ECG in our explanation. So SVT-AF, the explanation of the condition is same. So you explain that it's atrial fibrillation, then you draw the picture of heart and say that your heart is having, your heart is pumping faster and it's pumping irregularly. Your heart is not getting enough time to fill in, so your brain is not getting enough blood and you're feeling giddy. So exactly same kind of explanation. You just add irregular pumping, that's all. The next task is, what is the cause of atrial fibrillation? There is a lot of cause of AF. You need to explain at least a little bit. So say that it could be due to high blood pressure, could be heart attack or coronary artery disease, which means that your heart blood pipes are not getting enough blood supply. Could be abnormal heart valves. So your heart has some door-like structure known as valve, which control flow of blood in your heart. If there is any heart valvular problem, you can also get this kind of palpitation. It could be the heart defects that you might be born with, which we call congenital heart disease. Can be an overactive thyroid gland or any other metabolic imbalance. Could be exposure to some stimulant like some medication, excess coffee, tea, or alcohol. And sometimes some lung condition, previous history of heart surgery, even some viral infection or stress can also cause this kind of palpitation. If the task asks about cause of AF, you should always talk about 4 or 5 things at least. One of them is hypertension, ischemic heart disease, thyrotoxicosis, valvular heart disease. These 4 are the commonest cause of AF. There are, in very rare causes, you don't find any cause, which we call lone atrial fibrillation. You can always add that in some cases there are no causes, and that is what we call as lone atrial fibrillation. So these will be your causes of AF. And what are the complications? 2 most important complications is stroke and heart failure. In atrial fibrillation, the chaotic rhythm in your heart may cause the blood to pool in your heart's upper chamber known as atria, and it can cause formation of clots over there. Now, if a blood clot forms, sometimes it can dislodge from your heart and travel to your brain and block the brain blood supply, causing a stroke. In atrial fibrillation, if the heart rate is not well controlled, it gradually starts to weaken your heart muscle, and then it eventually leads to heart failure, which is a condition in which your heart cannot pump enough blood to meet your body's need. So these are the 2 most common complications of atrial fibrillation, but please don't worry. Now that we know that you are having it, with appropriate treatment, this complication will not happen. See this reassuring part, it's so important for the exam. Anytime you say some complication or something bad, which can scare a patient, you should always make it as a sandwich approach, which means you always say something nice, say something reassuring to them. And it doesn't mean that it will be a lie. It's normal, right? If you are controlling the heart rate, these complications will not happen. Yeah, that's same, Dr. Nidhi. Lone or idiopathic is same thing. All right, guys, any question? Now, same with the atrial fibrillation, management is not so important, but again, if they ask you, you should know. So management depends on the vitals again. If patient is unstable, that patient go for DC cardioversion immediately. If it's a stable patient, then management depends on 2 things. First, you can control the rate or you can control the rhythm. Controlling the rate is mainly by rate controlling medication. One is your beta blocker, like metoprolol, atenolol, all those things. And you can also try calcium channel blocker, which is the rate limiting calcium channel blocker, like diltiazem, okay, or verapamil. If rate limiting drugs doesn't help, you can control with the rhythm controlling drugs. Rhythm controlling drugs are those which are the anti-arrhythmic drugs, like you can use flecainide, sotalol, okay, or even amiodarone. Those are the commonly used anti-arrhythmic drugs for rhythm control. If rate or rhythm control does not help, then your last option is DC cardioversion again. Management of AF does not finish here. It's very important. If management comes, you have to address that AF patients are a high-risk population to have clot in their brain, right? Or anywhere else in the body. So you need to use the CHATS-VUSC2 scoring system to find out if they are a high-risk patients to have a clot. If the CHATS-VUSC score is more than 1, that patient will need warfarin. Okay? Now, Those things I would not go in detail because it doesn't come in exam exactly like this, and it's very hard for you also, they know about it, but I would advise you just to give it a read at least once, that what is chest versus score, and how to manage AF just a little bit. Okay, but if you know until this that the management is rate control by beta blocker or calcium channel blocker, followed by rhythm control by amiodarone, sotalol, flecainide, and then DC cardioversion, and then lastly, making sure that to prevent clot formation, we have to use a Chad's-Vasquez scoring system. That is scoring system, if it's more than one, that patient needs warfarin. Yes, Dr. Oishi. In case of face-to-face exam, one of the tasks is to perform physical exam on the patient. Those are the physical examination station. You have to talk it to the patient most of the time, Dr. Jahidul. All good, guys. So these are mainly the palpitation clusters which are important for exam. We are going into the another cluster now, which is chest pain cluster. Now, causes of SVT, Dr. Reham, can be anything, like any of the AF causes can be SVT related causes also. Now, SVT can be due to any structural heart disease, can be due to ischemic heart disease sometimes, and very commonly it happens without any reason in a young population. Sometimes dehydration can precipitate SVT, sometimes excessive exercise can cause it, sometimes valvular heart disease can cause it. Hypertension can cause it. Okay, so it's more or less the heart related conditions. Any existing heart condition can end up having a SVT as well. Excess tea, coffee can cause SVT. So those are all the causes. Usually they don't ask you the causes of SVT, they ask you the differential diagnosis. So it's more or less same. All right, guys. So chest pain cluster, we are going to start it after a 5-minute break. Okay, keep your head clear so that you can give your full attention to chest pain cluster. It's so important for exam. You will find out. So let's take a 5-minute break before we start this cluster. Thank you all. All right, guys, so let's start again with the chest pain cluster. So what are the differential diagnoses of chest pain? Now, chest pain cluster comes with a lot of differential diagnoses to remember. And most of the time in exam, you will end up getting the differential diagnosis mainly. So history and DD, that's all. And sometimes they will ask you to explain the ECG to the examiner. So what are the differential diagnoses of chest pain? Always remember CVS, obviously your main cause, then it could be respiratory related, could be GIT related, could be musculoskeletal, neurological, and psychological. For CVS related causes, angina, MI, or any of the ischemic heart disease is your most important thing to rule out, followed by pericarditis, aortic dissection, and aortic stenosis. In case of respiratory system, pneumonia, pneumothorax, and pulmonary embolism is the main cause of acute chest pain. In GIT, reflux or peptic ulcer disease is a cause. For musculoskeletal system, costochondritis is very common. You don't know that how many patients come in the general practice with a chest pain and then end up having costochondritis as a diagnosis. So it's a very common thing in general practice, and who knows, in your exam, sometimes this one can come. Okay, so keep it in mind. And normally costochondritis is a musculoskeletal pain in which patient will do a lot of heavy work and then end up having a sore chest. And when you touch their chest wall, it will be tender. So that's costochondritis. Rib fracture is very important to rule out. Neurological causes include prolapsed disc. So if you have a cervical or a thoracic disc prolapse, it can present with a chest pain. Herpes zoster is a very important thing to rule out. Like sometimes if you don't ask this question, you will never ever get the diagnosis. Like the patient with herpes zoster, they will have pain in the chest wall. And then 2 to 3 days later, the typical rash, which is vesicular rash, will come up in the chest wall. For psychological, it could be anxiety related or a panic attack. So panic attack, these are also very common cause of chest pain. Okay, so we have got CVS cause, lung related cause, GIT, musculoskeletal, neurological, and psychological. Now, about the history, a patient coming to you with chest pain, especially if they are middle-aged or elderly, they will always be very scared about heart attack. Everyone knows about it in Australia, and they're very aware of this. So you have to reassure them, and you have to give them enough empathy that you are there for this patient, and appreciate the patient for coming to you as soon as they have. So first, obviously, follow the same approach, introduce with the patient, give reassurance, make sure patient is vitally stable, offer some painkiller. Any patient in your exam, if they're having pain, you should always offer them painkiller. That's a vital step or a key step in the exam. All right. If a patient is vomiting in front of you, you should offer them antiemetic. If a patient having high fever, you should offer them a paracetamol at least. So those are the initial steps we always do in general practice or in the emergency department. So you just need to be aware of this thing. So let's say how we can approach this case. So say that, hi, John, this is Dr. Arshan, one of the doctor here. I'm really sorry to know from the notes that you are having chest pain. Now, would you please tell me a little bit more about how severe is your pain in a scale of 1 to 10? Doctor, it's 8 by 10. I'm so sorry to know that. John, I'll be able to give you some strong painkiller which will relieve your pain. But do you have any allergy to any medication? No, doctor. Well, I'm going to arrange a painkiller for you. You should feel comfortable after it. Now, a lot of you will ask that I will ask my nurse to give it to you. You will talk it to the examiner. That examiner, I would like to give painkiller to the patient. No need, guys. Just say that you would like to arrange a strong painkiller for the patient. That's all. Once you have done that, make sure patient is vitally stable. Say that, John, because you are having chest pain, I would like to make sure that you are vitally stable before I ask you any more question. Is that okay with you? In online exam, that's all you will do, and you will start asking questions. So, John, would you please tell me a little bit more about this chest pain? Now, patient will give you information. What you need to know is the whole Socrates questions of pain. Now, throughout the course, any pain questions, we will always follow the same Socrates approach. A lot of candidates follow different pain approach, but I use the Socrates one. So it totally depends on you. As long as you are using the same things and the important chest pain question, that's fine. Any question that you ask is okay. But what you really need to find out is that this is called Socrates pain assessment question. You need to know the exact site of the pain. You need to know the onset of the pain. So when did it start and what exactly were you doing when the pain started? What is the character of the pain, which means the type of the pain? Is it a stabbing pain? Is it a sharp pain? Is it a dull pain? Or is it a pressure, heaviness, constricting kind of pain? So we need to know the character. We need to know the radiation, that does it go to anywhere? Never ask to the patient that, does your pain radiate? Patient doesn't understand what is radiation. Say that, does your pain go to anywhere else? Associated symptom. Associated symptom, we always ask, like, along with the chest pain, are you having any shortness of breath, any nausea, any vomiting, any exhaling? Time or duration. That means how long this patient having the chest pain. E for exacerbating and relieving factor. So anything makes it better, anything makes it worse. And severity of the pain. We already asked it. So this Socrates question, we should always ask it in any pain questions. So that's exactly what we have asked. So John, when did it start? What exactly were you doing at that time? And did it come suddenly or gradually? Is it for the first time? Is it continuous or on and off? Can you exactly point out the site of the pain for me, please? And does the pain travel anywhere, like in your neck, in your jaw, or in your left arm? Can you describe how the pain feels like? Is it a stabbing kind of pain? Is it sharp pain? Or is it a kind of constricting pressure-like pain? Anything makes it better, anything makes it worse. Okay, so this is your chest pain question. Then go to the associated. Along with the chest pain, do you feel shortness of breath, any racing of your heart, any nausea, vomiting, or excess sweating? So you are ruling out myocardial infarction in here. Very, very important to rule that out. After that, go to the other differential diagnosis one by one. So for pericarditis, we get a sharp stabbing pain, retrosternal or left side of the chest. The pain characteristic is very important, and relieving aggravating factor is very important, and a recent history of viral infection is very important. So ask that, does your pain get worse when you lie down? And does it get relief when you lean forward? If you get yes to this question, you can always ask that, does your chest pain get worse when you take a deep breath or cough? Patient with pericarditis, usually they get a severe chest pain when they take a deep inspiration or breathing. All right, so ask that question. And it's a very important thing always to observe the patient. You can see the patient in video and obviously on face-to-face. Look at the patient. Always they will try to give you some clue. In pericarditis case, patient will lean forward. Okay, and that's a clue for you to understand that this leaning forward means something. Ask the patient that, did you have any recent flu-like illness? Almost every time you will get it positive in the exam or even in real life scenario. So that's pericarditis. For aortic stenosis, use the triad. So you remember that aortic stenosis patient get chest pain or tightness, shortness of breath on exertion. You already asked those two questions. What else you did not? Loss of consciousness. So ask that any dizziness or sudden blackout. For aortic dissection, there is no question that you have. Aortic dissection pain is sudden onset, severe central chest pain, which feels like tearing or ripping sensation. It's very severe, like 8/10 or 10/10, radiates to the back. Okay, and sometimes patient can be in shock as well, or sometimes patient can be severely hypertensive. So that's your aortic stenosis. That's your aortic dissection. But there is no question for that. The chest pain question that you are asking, that should cover everything. Okay. Now your serious questions are done. Go to the respiratory question. Pneumonia, pneumothorax, and PE. For pneumonia, the triad is fever, cough, chest pain, shortness of breath. Actually, it's tetrad. You already asked shortness of breath and chest pain. You have left with fever and cough. So any fever, any cough. For pneumothorax, any trauma to your chest recently, or you can also ask that, do you have any known lung conditions? Pneumothorax, again, the same chest pain, difficulty in breathing, which you already asked. For pulmonary embolism, any recent travel to anywhere? Do you have any previous history of clot in your legs or lungs? Any family history of clotting disorder? Pulmonary embolism, the same chest pain, shortness of breath, tachycardia, or palpitation. So that's your lung-related causes, which is done. Then go to the GIT system. For reflux or peptic ulcer disease, does your pain has any relationship with food? Any heartburn or frequent burping, indigestion? Any bitter taste in your mouth? Go to the musculoskeletal system, costochondritis. Only one question. So does your chest sore to touch, or is your chest sore to touch? You can rule out disc herniation by asking any neck pain or any back pain. For herpes zoster, have you noticed any rash on your chest? And lastly, you have psychological. So anxiety, stress, panic attack. You can ask that, are you generally an anxious person, or do you worry a lot about most of the trivial things? Anytime do you get a small episode of a feeling of chest pain, choking sensation, numbness around your mouth, or a fear of dying, that's you are actually asking about panic attack. If a patient is very young patient, female, and having a history of anxiety or psychiatric condition, having like multiple episodes of chest pain, shortness of breath, you should always think about panic attack or panic disorder. And then ask about SADMA, so smoking, drinking, recreational drugs. Ask about stress at home or work. Past medical history is very important. Ask about high blood pressure, diabetes, high cholesterol, or any heart condition. Family history of heart disease, and are you on any kind of medication? Same like before. So you can see that there is a lot to ask in here. Now, always remember, if your task is like 4 or 5 tasks in this case, you have to cut it short. Okay. So sometimes they already give you an ECG of MI or a pericarditis in the stem. When you get a ECG already, you don't need to ask all of these questions unless they ask you history and diagnosis and DD. If that is the task, then obviously you have to ask all these differential diagnoses. But if there are 4 or 5 tasks, you have to cut it out. Like you can always, like, you don't need to ask herpes zoster, then you can always rule out aortic stenosis, because you will get it eventually. If there is aortic stenosis, you will get a murmur in the physical exam. So some of these you can rule out, and don't bother too much with asking about a lot of smoking and those things. It's always depend how much task you have in the exam, and it's an important thing to learn as well, that how you can cut short your history based on the task and time you're having. All good? So then you go to the physical exam, same like before, nothing else that I have added apart from only one thing, which is pericardial rub. On auscultation, you have to add it. So apart from S1, S2, is there any added sound like murmur or any pericardial rub? In a patient with pericarditis, sometimes you get a noisy sound in the heart. Most of the time, examiner says that, yes, you can hear a noisy sound coming out from the heart. That noisy sound is the pericardial rub. And others are same. Let's move on to the case. Do you guys have any question with the chest pain cluster format? Those who are in Facebook, guys, feel free to ask any question in the comment section. I'll be happy to answer. Good. So a 50-year-old tram driver presents with sudden onset chest pain since 2 hours. Focused history, physical exam, diagnosis, and DD. Now, when a 50-year-old coming to you with a chest pain persisting for 2 hours, you should always think it as myocardial infarction first, unless you can rule it out. The positive points in the history is patient having a chest pain for 2 hours, aggravated by lying down and deep breathing, relieved by leaning forward, stabbing pain, can radiate to the back and in between shoulder blade, flu-like illness a week before, and no other symptoms. So it's all typical history of pericarditis. And when you have asked for a investigation from examiner has given you this ECG. What you can see in the ECG? When a patient has chest pain, you look for ST elevation in the ECG. That's again being smart in the exam. So you remember I said initially that in ECG there are chest lead and limb lead. Limb lead are lead 1, lead 2, 3, AVR, AVL, AVF. And these are your chest lead, V1, V2, V3, V4, V5, V6. Now, there are myocardial infarction in like a different type of MI. There are anterior MI, there are high lateral MI, there are inferior MI. How we actually say which one is what? Anterior MI means that there is ST elevation in chest lead. When we call it as an anterolateral MI, that's also involve your lead 1 and lead AVL. So always, if you get a ST elevation in lead 1, you look immediately in lead AVL. These are interconnected. So if someone having a ST elevation in V4, or you can say V2, V3, V4, V5, and also lead 1 and AVL, that's what we call as anterolateral MI. Now, if a patient has ST elevation in the anterior leads or chest lead, that patient should have a reciprocal ST depression in inferior lead. What is inferior lead? Lead 2, lead 3, and lead AVF. So if someone having a ST elevation in V4, V5, V6, and let's say in lead 1 and AVL, so you can say it's the anterolateral MI. What you need to find out in your lead 2-3 AVF. In lead 2-3 AVF, this patient should have a ST depression. That's called reciprocal ST depression. And it's almost every time you will get it in a ST elevated MI. Exactly opposite will be like if someone having ST elevation in lead 2-3 AVF, they will get reciprocal ST depression in the anterior leads, like V1 to V6. Now, if you look at this ECG, you will not find that reciprocal relationship between anterior and inferior lead. Look at this one first. So V1, nothing much. V2, it's starting to get a ST elevation. Always look at the baseline. So that's your baseline, okay? And ST wave or ST segment should always be in this baseline. Now you can see it's elevated. This is the baseline. See the ST wave, it's obviously elevated. Same V4, V5, and V6. Okay. After you have checked the V1 to V6, you immediately look at V1 and lead 1 and AVL. Lead 1 having ST elevation. Now you look at lead AVL a little bit. Okay, so you can say that it's an anterolateral MI, but you have to look at lead 2-3 AVF for that reciprocal ST depression. Now, if you look at here, see that lead 2 also having ST elevation, lead 3 nothing, lead AVF also having ST elevation. Now, this doesn't go with your reciprocal relationship. And when you get ST elevation in almost every lead, and there is a concavity upward like this, see the concavity upward, as if you can sit and have a drink in here. Okay, so if you have a chair-shaped or a concavity upward kind of ST elevation like this, and it's almost in every lead, that's pericarditis ECG. Is it clear for everyone? So how you will explain this ECG to the examiner? So just talk about, in here there is no, it will be very hard to say the rate and rhythm. Okay, so don't talk too much about the rate and rhythm. You can look at the rate from lead 2. Okay, talk about rate and rhythm, and then talk about P wave, QRS complex, mainly focus on ST segment elevation. Always say that where you are getting the ST elevation. So you can say that there is ST segment elevation in V2 to V6, lead 1 and AVL, and lead 2 and AVF. As the ST segment elevation is global and it's a concavity upward, I am suspecting it's a pericarditis ECG. Sometimes in pericarditis, you also get PR depression, but I can't see anything in here. So if you get a PR depression, you can always say that. Okay. So PR means this part. Okay, so explain. Most likely you are having a condition known as acute pericarditis. Do you know what it is? No, doctor. Well, this is a condition where there is inflammation of the outer layer of your heart, which we call pericardium. Most likely it happened as a reaction of the viral infection that you had a week before. As the covering of your heart is inflamed, it's causing this stabbing, sharp pain, which gets worse when you lie down and gets better when you lean forward. Now, it could be due to other reason as well, like it could be a heart attack, but let me assure you that it's not heart attack because your ECG doesn't say so. And the chest pain, the character and type of the pain you are having, it doesn't go with the heart attack. But it's still, just to rule that out, I would like to keep you under observation in the hospital. I will call my senior and we will do further investigation to rule out heart attack. And then give all the differential diagnosis of chest pain as well. What investigation you have to do? Obviously, you have to talk about cardiac troponin Along with that, you will do repeat ECG. You can also do some full blood examination, inflammatory marker, kidney function, liver function, and the echocardiogram. If it is confirmed to be pericarditis, then there is nothing to worry about. You just need to take bed rest, and we will just give you some painkiller for your pain relief, and you will be able to go home today. And then just give some 4R. That means say that I will write a letter to your GP who can review you. If by any time, if at any time your chest pain is severe, and if you get a chest pain, along with that you're also having nausea, vomiting, sweating, if the chest pain persists for more than 15 minutes and it goes to your left arm, neck, or jaw, please call 000 or call your doctor or your GP immediately. Okay, so that's your red flag. You can also give some reading material. Now, at the moment, reading material is not important because you are keeping the patient under observation and admitted at the moment. If you discharge someone, then you should always give a reading material to them at that time. In here, mainly say that once everything is clear, you will write a letter to the GP who can follow up this patient. And this patient does not need to come to your ED or come to the medicine outpatient department for now. If it turns out to be a case of heart attack, then obviously the whole management will be different. But most likely you don't need to go in that direction. Just say, give some reassurance that it's not a heart attack and say that you will write a letter to the GP. But always remember, even though it's a pericarditis, you have to do cardiac troponin and the echocardiogram. Okay, it's just a precaution that we always follow. Next, acute MI. Very important, guys, for the exam. A 55-year-old man comes to your ED with a sudden onset of crashing chest pain. Looking at this, you will think about, well, this is a MI patient. Same kind of task. Now, positive points is acute onset of severe chest pain, crushing in nature, radiating to jaw, neck, left arm for the first time. Associated nausea, vomiting, shortness of breath. Patient is a long-term smoker, no other heart condition. Now, it's a very important thing, guys, like if you get a patient with a chest pain, even the previous case that we have done, the pericarditis one, as long as you are not sure that it's not a MI, you should always treat it as a MI. All right. So what do I mean by that? It means that a patient having a crushing chest pain for 2 hours, we should always start the management of MI unless we can remove that cause or unless we can prove it otherwise. So when you get it in the exam, a patient 50-year-old getting a chest pain for 2 hours, crushing in nature, what you need to do initially before starting your history, that's important. And sometimes some of the cases, you will already get a ECG showing acute MI in the stem. And obviously at that time, you have to start the monotherapy even before starting your history, because that patient cannot wait for 8 minutes to get an aspirin from you. Because every minute you are asking history, heart muscle is dying. And you can save that just by giving this aspirin. Okay, so it's a very, very important thing to follow in real life as well. You never ever wait for a troponin to confirm MI and then give aspirin. If you suspect it as a MI, you give monotherapy, then do anything that you want. So what will we do in here? We will follow the monotherapy in here. So first of all, let's say a patient coming to you with chest pain like that, and you would say that, hi, John, this is Dr. Arshan. It's very nice to meet you. I'm very sorry to know from the notes that you are having chest pain. Please don't worry, now that you are here, I'll try my best to find out why you are having this chest pain and manage you accordingly. Now, John, would you please tell me how severe your chest pain in a scale of 1 to 10? So, and then just similarly offer some painkiller to the patient, making sure patient doesn't have any allergy. Once you have done that, you have to ask vitals from the patient, from the examiner, if it's a face-to-face. So ask for hemodynamic stability. Now, whatever is the vital doesn't matter. No, like most of the patient with MI will not be hypotensive, will not show any sign of shock. Even though their vital is stable, you have to take this patient to the resuscitation room, attach the patient on cardiac monitor, ask the nurse to do a ECG, secure 2 large wide bore IV cannula, take blood for full blood examination, cardiac enzymes, including the troponin, and also you can do some other investigations like other blood, like coagulation profile on all of those. And if the patient's saturation is less than 95%, you should also start the patient with oxygen. Okay, so you already offered painkiller. That is strong painkiller is the morphine. So that's a part of monotherapy. You talked about oxygen. Now, 2 other things you haven't talked about. One is nitroglycerin, another is aspirin. Say that you would like to start this patient with 300 milligram of aspirin by mouth, and also nitroglycerin, making sure patient is not hypotensive. Okay, so this should be done first. Now, why I kept aspirin and nitroglycerin just not at the moment? Sometimes, like if management is a task in the exam, if you are just saying that in management, they will not fail you. So it depends how you want to do that. As long as you are talking about aspirin, morphine, oxygen, nitroglycerin, either at the first or during your management portion, you are fine. They don't fail you for doing it at the end. All right, so it totally depends on you, how you prefer it. But normally in my aspect, I would always start it at first if I suspect that this patient might have AMI. And especially if in the stem, the ECG is already given and I can see this patient is having acute ST elevated. Okay, so again, so once you have given the painkiller, you have asked about hemodynamic stability, then whatever is the vitals, you say that doctor, because of my patient age and the onset and duration of chest pain, I would like to take my patient to the resuscitation cubicle, attach him on cardiac monitor, do an ECG, secure 2 large bore IV cannula, take the blood for cardiac enzymes, including troponin, and offer the patient aspirin and nitroglycerin as required. Okay, so that's how you should say this line. This is very, very important, guys. You can't miss this monotherapy in an acute MI case. If you miss it, you are done. Okay. Strong painkiller is fine. You don't need to mention morphine. If you mention it, that's fine. You don't need to say the dose of it. But if you want to say that you want to give morphine, that's fine in this case. All right, now let's look at some of the ECG for acute MI. If you get a patient with chest pain, you should always look at from V1 to V6. So in V1, you can, in here you can see some ST depression, V2 ST depression, V3 ST depression. This ECG, I would not be so much bothered. In my view, it's like there are some artifact in here, like this patient having lateral and also inferior MI. Okay. Let's discuss this one. This one will not confuse you too much. If you look at here in the V2 to V6, in V2, this is the baseline or isoelectric line. You can see that this is called J point. okay, where you see the ST segment. So this is ST segment elevation, and you can see the J point very thoroughly in here. So that's your isoelectric line and ST elevation. In V4, there is ST elevation, V5, V6, ST elevation. Look at lead 1 and AVL. Lead 1 having ST elevation, lead AVL having ST elevation. You can immediately say it's anterolateral MI. Look at lead 2, 3 AVF. Now, remember, sometimes there might not be any depression. The lead 2, 3 AVF can be totally normal. That's also fine. So this is normal. Lead 3 having some kind of ST depression in here. Lead AVF normal. So that's fine. As long as it's not elevated, we are good. Okay, so this patient having anterolateral MI. Now tell me what you have found out from this ECG. So let's look at one by one. So V1 ST elevation, V2 obviously ST elevation, V3, V4, V5, V6 not too much. Lead 1, lead AVL, sorry. So anterolateral MI already, and lead 2, 3 AVF is fine. So this patient obviously having ST elevation in V1 to V4, including A1 and AVL. So anterolateral MI again. If you don't want to say the type of MI in exam, or you are not sure, you can always say ST segment elevated anterior MI or ST segment elevated MI. As long as you are saying ST segment elevated myocardial infarction, you are good. Okay, now the management. So say that, John, thank you so much for waiting. Now, John, based on the nature of your chest pain and according to the ECG, most likely you are having a condition known as acute myocardial infarction or heart attack. John, I am really sorry to say that. John, it's a serious condition. And in this condition, the blood pipe that supplies your heart get blocked by some clot or fatty deposition. And as a result of that, your heart muscle does not get enough blood and oxygen, and it starts to die or become non-viable. And that eventually can lead to serious complication. Please don't worry, John, you are in safe hand. It's very good that you have come early, and with proper intervention and management, it can be treated very effectively without any of this complication that I talked about. But I need to admit you in the hospital. I will call my senior and the cardiologist who will come and review you as soon as possible. In the meantime, now in here I have written aspirin. If you forgot to mention that initially, don't forget it now. So in the meantime, I am going to give you a tablet known as aspirin, which you need to chew only. And this will save your heart muscle to get damaged more. I have already given you a strong painkiller and will continue until you feel uncomfortable. If you're still having ongoing chest pain and your blood pressure remains stable, I can also give you another medication known as nitroglycerin, which can relax your heart blood pipes and give some more blood supply to your heart muscle. Anytime your oxygen saturation goes down, I would also start you with oxygen. The specialist will come and review you, and also they would do some blood tests like a full blood count, your kidney liver function, your blood sugar lipid profile, and troponin. The definitive management of this condition is to remove the clot and restore the blood flow, which we call percutaneous coronary intervention or thrombolysis. In this procedure, they will take you to a catheter lab, and you will be managed by a multidisciplinary team of specialists, including a cardiothoracic surgeon, anesthetist, and interventional radiologist. They will take you to the theater as soon as possible to remove this clot by this procedure. This procedure will be decided by your specialist based on your duration and severity of the condition. All right. Now, because it's very important to know how long this patient having this chest pain. Is it 12 hours past or not? If the patient present to you within 12 hours of onset of symptom, the PCI is still a choice. Okay, so you should always say that the management does not include to discuss about PCI, guys. So don't go in detail about PCI. You just need to say that you will also involve the cardiologist who is going to manage this percutaneous coronary intervention to retrieve the clot and restore the blood flow in your heart blood pipes. That's all. Okay, never ever go in detail about this at this moment, because you will not be able to finish it in time. Now, because this is an acute case, you don't need to talk about this once you are discharged, what you are going to do, adopt a healthy balanced diet. This will be done when the patient will be more stable and when you are going to discharge this patient. You can just say that at the moment, the main focus of our management will be to restore the blood flow. Once that's done, you are good. And then even after a few days, you will be able to go to your home. Once we are going to discharge you, the specialist will put you on some more medication, which will help your heart to have good, good function like before. I will discuss that with you once you become more stable and after your operation is done. I would also like to give a phone, or I would also like to contact your friends or family members if you want. John, I want you to know that sometimes having a heart attack can be very serious. But the good thing is that you are here, and it's very good that you came here within few hours of chest pain. And when you have done that, you have done your part. And now it's our job to make sure you go to your home without any complications. And we have a very good team of doctors here who will make sure that you feel as comfortable as possible. If you want me to call any of your friends or family members, I would be more than happy to do so. But please don't get worried about it. You will be fine. Okay, so that's how you finish this kind of cases. It's very, very important that you reassure the patient, because this patient has fear of dying, remember? So it's very important. Clear, guys? Any question? All good, guys? All right. Now, let's discuss another case related with angina. Now, this is not acute chest pain. Patient will present to you with a chronic chest pain. So 62-year-old male who presented a few days ago with chest discomfort. ECG done at that time was normal. A stress test was done later on, showed ST segment change in anterolateral lips. Patient had chest tightness during the test. He is a smoker, no history of diabetes. Explain the test result and give short and long-term management. So that's angina, right? So when you get a patient with a ST segment changes in the stress test, that means this patient most likely having a stable angina. So say that, John, so you introduce with the patient, you reassure the patient and say that, John, the condition most likely you are having is known as angina. You can also discuss the test result a little bit. Say that, John, remember that you had some chest discomfort few days ago, and we did ECG, which was normal. Because you are 62-year-old and you have risk factor, I sent you for a stress test where you had to run on a treadmill, and we were looking for any changes of your ECG during stress. And we have found out that while you were running on the treadmill during the stress test, there was chest tightness that you felt, and also there was some ECG changes suggesting that most likely you are having a condition known as angina. So this is a good start of this thing. Now, do you know what angina means? No, doctor. Well, it means that it's a kind of chest pain or discomfort that comes from your heart when it is short of oxygen. Your heart is supplied by some blood pipes, like all other parts of your body, and those are known as coronary arteries. In this condition, the blood pipes that supply your heart muscle get narrowed due to deposition or accumulation of some fatty substance. As a result of that, when you do some exercise, your heart can't get enough oxygen, and that's the time when you experience chest discomfort or pain. John, please do not worry. It's a very common condition. Millions of people are suffering from this. But unfortunately, it can lead to a serious complication known as heart attack, in which condition your heart blood pipe will be completely blocked, and some part of the heart muscle will not be able to get any blood supply. And that's why it is very, very important to have a preventive management so that you don't end up having a heart attack in near future. The most important thing to do at this time is to follow a healthy lifestyle to prevent this heart attack in future. Now, in terms of management of angina, first thing that I would like to do is to order some investigations to find out your cholesterol level. We'll do your blood sugar to find out if you are having any diabetes or not. And also I would like to do your liver function test, kidney function test, your thyroid function test, and also you can just do a normal baseline blood test as well. So it's always important in any angina patient, we always do a metabolic screening. The metabolic screening includes taking full blood count, then liver function, kidney function, thyroid function, blood sugar, and lipid profile. Okay, so order those investigations and then talk about further management. Further management divided into lifestyle modification and some medication. In terms of medication, I will start you with aspirin, which will prevent further clot formation. I'll also give you some good medication to remodel your heart, which is beta blocker. Also, I would start you with cholesterol lowering medication known as a statin. And also I will give you a medication which can relax your heart blood pipe when you are getting this chest pain known as nitroglycerin. You need to start taking all this medication as I prescribe. So this is very, very important that you say that you would like to start this. If patient is having high blood pressure, you should also start the patient with ACE inhibitor. And in terms of lifestyle modification, please try to cut down alcohol to the safe limit. Make sure you do not smoke at all. Please try to maintain an ideal body weight, and please take healthy balanced diet. Try to do some exercise, ideally 30 minutes of walking on most of the days of the week. And please avoid any stressful works. For further management, I would also refer you to a cardiologist as soon as possible for further assessment and management. Most likely, because you have some changes in your stress test, they are going to do another test to confirm the level and degree of blockage of your coronary arteries. The test that they most likely will be doing is called coronary angiogram. Angiogram is a test in which they will insert some dye into your blood pipe, and it will reach your heart blood pipe, and it can show how much blockage you are having. And depending on the level of blockage, the next step will be decided by your specialist. They might put a stent to keep the arteries open after ballooning it, or sometimes if there is a high-grade block, they can also want to do a bypass surgery. Your specialist will discuss in detail if your angiogram shows any of the high-grade features as I discussed. Now, you don't need to go in detail of angiogram, okay? Just touch the point. If you again have this sort of chest pain, please follow the angina action plan. That is very important. If you have prolonged pain, even after taking rest, take this nitroglycerin tablet or a spray that I have prescribed, and then wait for 5 minutes. If not relieved, notify a friend or relative that you are having the chest pain. If even after 5 minutes, the pain persists, take another dose and wait for another 5 minutes. If not relieved, even after taking the second dose, call the ambulance, take the third dose, and tell the ambulance that you are having a heart attack. Okay? And then lastly, finish with 4R. Angina action plan means you take nitroglycerin spray 1 dose, wait for 5 minutes. Even after 5 minutes, there is chest pain. You call the ambulance, take the third dose, and say that I'm having a heart attack. Okay? Very good question, Dr. Yusuf, that if it's a rural area, how we deal with MI case. In case of rural area, it's very important to know the onset of chest pain, especially, let's say, if the rural hospital is more than 2 hours away from the tertiary hospital, then you don't have that time to send the patient to the tertiary hospital for the catheter lab to do the PCI. You have to go for the thrombolytic agents like altiplase, retiplase, those thrombolytic drugs. Okay, so it depends on how far your rural hospital is. If rural hospital and the tertiary hospital distance is more than 2 hours, we don't have that facility to, or we don't have that time to wait. Okay, so 2 hour waiting is not ideal. Where the patient is with you, you can give the thrombolytic to the patient, but you have to talk with the cardiologist in the tertiary center. If they are happy for you to go for the thrombolytic, you will go for the thrombolytics. Okay, making sure patient doesn't have any contraindication to thrombolytics. Like, what are the contraindication? The patient does not have any active bleeding from anywhere, no history of bleeding disorder. Patient did not have any stroke, especially any ischemic stroke in the last 3 months. No previous history of intracranial hemorrhage. These are the absolute contraindication. If those contraindications are not there, you can start thrombolytic for the patient. And once patient is stable, you can send the patient to the hospital later on, like tertiary hospital later on. Sometimes, even though if you can send the patient through air, it might take even 2 hours, because you can't just say that like air ambulance, it needs time to come to your hospital or your GP center, and then it also needs to travel the patient to the tertiary hospital. Sometimes even it takes 5-6 hours, even a day. Okay, it's not that easy. So it depends on how far your hospital is. If air ambulance can make it done within 2 hours time, then you can give it a try. All right. The next case is a 50-year-old man in your GP clinic complaining of chest pain and dizziness for the last 1 month. Now, see that it's 1 month chest pain. If someone having 1 month chest pain, it's most likely not a acute MI. Okay. So in this case, the patient is having dizziness and chest pain. But still make sure patient is vitally stable, offer the patient painkiller. And the positive point in the history, that patient having chest pain on and off, 5/10, not so severe, retroesternal, comes and goes, precipitated by effort, relieved by rest, radiate to the neck, jaw, shoulder, and arm. So it's a angina kind pain. Patient also have dizziness, especially patient feel dizzy or weak when they change their position from sitting to standing. So possible postural hypotension, right? Patient is a smoker and alcoholic, cholesterol normal, all other things are normal. On physical examination, patient have a postural drop of blood pressure. Apart from that, everything is normal, but you have found out if you have done DRE on this patient, you will get a blood in your examining finger. Always remember, if someone having angina, you should always rule out anemia as one of your differential. Why? Because anemia itself can cause angina kind of chest pain. And in a patient like above 50, if they're having anemia, you should think about they might be having either it's a bleeding peptic ulcer, either it's a gastric cancer or a stomach cancer, or it's a cancer in the GI tract, like it's colon cancer. So you should always think about, like, is this angina having some underlying cause? So the history will be first start with chest pain question, followed by dizziness question. So can you tell me more about your dizziness? Anytime have you got loss of consciousness? Any relationship with change of position? Ask about associated symptom, then all the differential diagnosis of chest pain. When you are asking anemia question, patient will say, yes, doctor, I feel quite tired these days. When you get this positive, you need to go in detail of anemia question. So what can cause anemia? Maybe dietary problem, malabsorption, or bleeding from anywhere. So do you take healthy balanced diet? Rule out possibility of cancer also. So any loss of weight, any loss of appetite, any lump or bump anywhere. Ask about, have you noticed any change in color of your stool or urine? That's because you want to find out if the patient having any occult bleeding in the stool. Trying to rule out peptic ulcer or stomach cancer. So any history of heartburn or indigestion. Any pain in your tummy. Have you noticed bleeding from anywhere in your body? Any change in your bowel motion? It's like patient with GI tract cancer, they will always have recent change in their bowel motion. So we are trying to find that out. Okay. So just remember, if anyone having anemia, you need to find out their diet. You need to find out if they are having bleeding from anywhere, especially in their stool or urine, and also ask about their bowel habit. Like it could be malabsorption, like chronic diarrhea, or it could be change in their bowel habit, which can suggest colon cancer. In the past medical history, specifically ask about any history of peptic ulcer disease. So that's pretty much same. You're just adding the anemia question in here. In the physical examination, general appearance, pickled. In the pickled, you will get pallor positive. In the vitals, you will get postural hypotension. Sometimes BMI, you can get a little bit of low BMI. Serious you will do as it is. You have to add abdominal exam in here. Do not forget to do DRE in this patient. Okay. And when we do DRE, yes, you have to always say that with the consent of the patient and presence of a chaperone, you would like to do the digital parectal exam. When we do the abdomen clusters, we will discuss it. Okay. Now, how to manage this case? Say that from history and physical exam, most likely you are having a condition known as angina due to anemia. Do you know what it is? No, doctor. Well, anemia means lack of blood in your body, which is most likely due to loss of blood from your back passes. When I checked your back passes, I have found some blood in my examining finger. And due to lack of blood supply, your heart is not getting enough blood and oxygen. And that's the reason why you are getting this chest pain or discomfort during exertion, which we call angina. Please don't worry. Now that you are here, we'll try our best to manage your symptoms. Right now, I need to admit you to the hospital because you might need some fluid because you are having some like lack of blood pressure or you're having some low blood pressure, especially when you are changing your position. You will also be seen by a gastroenterologist and a heart specialist for further investigation and management. They will do further investigation like full blood examination to confirm anemia, inflammatory marker, ECG, iron studies, blood grouping and cross-matching, your liver function, kidney function, and cardiac enzymes. You can always say that why you want to do this test. Like you want to do full blood examination to confirm anemia. You want to rule out any inflammation, so you do inflammatory marker. You will rule out any possibility of any heart condition by doing ECG and cardiac enzyme. You will check for iron deficiency by doing the iron studies. You will do blood grouping and cross-matching to find out if this patient needs blood in future. This will help you with that. So if you have time, you can always explain why you are doing this investigation. Your specialist, especially the gut specialist, might also want to do further investigation to rule out any cancer or nasty changes in your gut. Most likely, they would want to do endoscopy and colonoscopy. In this procedure, a flexible tube will be passed from your mouth into your stomach to find out any suspicious lesion over there. And also, a flexible tube will be passed through your back passes into your gut to look for any suspicious changes. Please don't worry. This procedure will be done while you will be under anesthesia or you will be in sleep. You will not even feel any kind of pain during this procedure. Right now, the most important focus of management is to stabilize your condition and find out the underlying cause. Once it is found, you will be managed accordingly. Please don't worry. It is not a heart attack. It's the lack of blood supply which is causing your chest pain. Okay, so that's how you manage angina due to anemia. Very important, guys. Sometimes it becomes very tricky in the exam if you don't know about these kind of things. All good. So I think like what I would like to do, there is another cluster, just 2 questions, which include your serious risk assessment. I think like tonight it's too much for all of you, and you will not even remember what I'm saying. I will keep the serious risk assessment for the role play session that we are doing. So we'll do the role play on this one at first, and then we'll go for further role play. Okay, that should be fine, I guess. And it's very easy. We'll just discuss this chart as well at that time. All good then. let's finish it here tonight because it's a lot you guys have learned tonight. I think like it's not a good idea to go for everything in one class. Any question on our tonight's session, guys? Did you guys like, are you guys getting interest in the class? The most important thing is to feel interested and feel satisfied with the learning. And I can see someone you asked, like if in MI question, it's mentioned patient has bleeding peptic ulcer, what should be the approach? Remember one thing, Dr. Arifa, that is exactly just the opposite kind of case. Okay, now if a patient having a history of bleeding peptic ulcer disease, we would not go for thrombolytics in that patient. That patient should have PCI. But these are the cases which need a specialist input, okay? Because for someone who is having active bleeding peptic ulcer disease, you can't give thrombolytic. That's a relative contraindication. In those situations, it's always in the exam, you will never ever give the exact management. You will say that these are the two options we have got, but because you are having this relative contraindication for thrombolytic agent because of bleeding peptic ulcer disease, your management needed to be decided by a cardiologist. I will discuss with them and the further management will be according to them. It's a very complicated approach for someone who had a bleeding peptic ulcer and you can't send the patient to the tertiary hospital for PCI. Okay, most of the time we have to take the risk just to like patient will not die out of bleeding peptic ulcer disease, but they will die out of an MI. So you just need to take that risk most of the time. But that decision is not onto you, it's onto the specialist. Thank you, everyone. So I think we are just going into the most of the like finishing of the 2-week session. There is only one session left, which is your cardiology role play session. And we are going to start the full 5 months course just after this free 2-week session. So we'll have an orientation session just in the next week after this free 2-week session. So if you guys want to enroll the 5 months course, this is the time where you should start contacting us so that you can start that process. Okay, it takes a little bit of time to get into the course, getting access into the software and everything. So if you are interested, this is the time you should start contacting. I hope that this is helping you and you are feeling interested about the exam and don't get disheartened. And also one of the important thing is like, you will find out that it's very tricky that am I going to go for the job application or am I going to finish the clinical exam first? Now, if you get a job, you should go for the job. Never ever think twice about it. But even if you get a job, you have to pass clinical exam. There is no alternative apart from very few times. There are some alternatives which we will discuss later on, like a workplace-based assessment, WBA, and it's not so easy to get. And not every hospital offer it. So always you have to go for clinical exam in any way to get your general registration. So if you are thinking that like anyhow I'm going to bypass clinical exam, in the long run it will be quite impossible. Okay, that's actually coming from the experience. I have seen a lot of hospital doctors with a limited registration not getting the clinical exam pass, and then it becomes so hard for them to continue the hospital job as well, because you have to pass clinical to continue the job as well and to get the general registration at least. So it's very important to balance these two things. Getting a job is important, passing the clinical is also very important. So that balance should come into your head. As soon as you can pass clinical, you're done. Okay, at least for the next 3-4 years, you are done. Then you will think about a specialist exam or a lot of other things, but at least for a couple of years, you are done. You don't need to think twice. Clinical exam is important. Okay. And we'll discuss about some of the pathways and everything. We are trying to get that class arranged. Most likely this month, we will discuss about some of the pathways that you can look for. And also for the course student, we are going to arrange some job hunting approaches and some of the pathway approaches that will eventually help you in the long run. Okay. So hopefully you guys enjoyed the sessions and everything. And I hope that this is still interesting for you. Thank you all. Have a good night. We'll see you in the next class. Try to finish this cardiology theory so that you can do role play with us. Okay, bye. Good night.